Sir, give me 1 minute, sir, and we'll start. Balaji, are you with us, Balaji? Balaji?
Yes, sir. I have joined, sir.
Can you try sharing your PowerPoint, ma?
Yes, sir.
Make your screen full screen. Yes. Are you make it full screen, ma?
Yes, sir.
So I think we will start the session. We have the invited faculty. Dr. Suresh Kumar is the surgical oncologist. He will be shortly joining. We have Professor Anandi Madam, Professor of Surgery from Stanley, and then Professor Asit Patel, sir, Professor and HOD from Ahmedabad NMDC, AMC Met Medical College. And we have our faculty panel, Professor Khanna, sir, Jailal, sir, Srinivasan, sir, Rajiv Sahai, sir, Karnakaran, sir, and others have joined us. So we have two important cases for discussion today, kindly contributed by Professor Kannan, sir, and Professor Srinivasan, sir. So we will have the first presentation on ulcer lip. I think he has given the diagnosis, but it's fine. Dr. Balaji, please introduce yourself, your unit chief, and go ahead with the presentation. Faculty, kindly take over.
Yes, sir. Hello? Am I
Yes,
audible?
Balaji, you have to switch on your video, Bala.
Yes, sir.
You have any challenge, Bala? I'll ask Karthi to present first.
Sir?
No, we are unable to see you, ma. You have any challenges in switching on your video?
Yes, sir.
Now we are able to see Balaji.
Yes.
Yes, sir.
Okay, ma. Go ahead. Please start.
Okay. Yes, sir.
Some noise are coming.
I will handle, sir. I will handle. Suresh Kumar, sir. Good evening, sir. Thank you for
Good
joining,
evening, sir.
Sir, light is on your back, sir. Suresh, sir. Can you please change your question, sir? Light is behind you, sir. So now it is better, sir. Moving to the other place. Yes, sir. Perfect, sir. Perfect. Yes, sir. Can we start, sir? Bala, please go ahead, Bala.
Yes, sir. Good evening, sir.
Good evening.
Good evening, every faculty is present here. First of all, I like to thank Dr. Kanagavel, sir, for conducting this wonderful session. As well as I would like to thank our Director IGS, Dr. Professor Kannan, sir, for giving me this opportunity to present this case on this forum. And I welcome all the faculties present here. And I would like to proceed with my case presentation. Yes, sir.
Go ahead.
Go ahead. You are going good.
Coming to my case, 68-year-old male, Mr. X, hailing from Dharmaburi, who is a daily wager by occupation, presented with complaints of ulcerative growth over his lower lip for the past 4 months. With history of presenting illness, the patient was normal, after which he developed an ulcer over the lower right inner aspect of his lip.
Bala, go ahead, Bala.
Okay, sir. The patient was apparently normal 4 months back, after which he developed an ulcer over the lower right inner aspect of his lip initially, that gradually progressed to form an ulceroproliferative growth, now involving almost the entire length of his lower lip. This ulceroproliferative growth was insidious in onset. It is associated with pain, but it's not associated with any bleeding.
Romeo, mute, sir.
Go ahead,
Go
Balaji.
ahead, Ma. Go ahead.
Okay, sir.
Go ahead.
There is a history of pain over the ulcer-proliferative growth, which is insidious in onset, intermittent in nature, dull aching type. It's not radiating or not referred to here, and the pain is aggravated while chewing and eating. He also has a difficulty of while chewing, and there is no history of any fever. There is no history of any trauma to his lip. There is history of foul-smelling breath. Halitosis is present. No history of excessive salivation. No history of any pus discharge from the ulcer-proliferative growth. No history of any difficulty in speech or swallowing. No history of difficulty in opening the mouth or protrusion of tongue. No history of any hoarseness of voice. No history of cough with expectoration. No history of chest pain or any breathlessness. No history of any hemoptysis. No history of any loss of weight or loss of appetite. No history of neck swelling, any neck swelling. But he has any history of betel nut chewing. Coming to the past history, the patient is not a known case of diabetes or hypertensive, CAD, CKD, or pulmonary tuberculosis or bronchial asthma. No history of any sexually transmitted diseases. No history of any previous surgery. No history of any dental extraction. No history of any chronic drug intake or drug allergy. Coming to the personal history, the patient takes a non-vegetarian diet. He has a normal bowel and bladder habits. He has a normal sleep pattern with normal appetite. He is neither a smoker nor an alcoholic, but he is a chronic betel nut chewer, consuming about 10 to 12 packs per day for the last 15 years. Coming to the family history, there is no similar illness in his family members. On general examination, the patient is
Balaji, there will be some questions on the history, then you can go ahead.
Okay, sir. Yes, sir.
Balaji, how did you know that the patient had the patient did it tell that it is a ulcer-proliferative growth?
Yes, sir.
In the history?
Yes, sir. He initially had an ulcer over his inner aspect of lower rib, gradually increased in size and grow outside, sir.
No, when we talk about the history, it is in the patient's language, isn't it? So can the patient say it is ulcer-proliferative growth? He will say either an ulcer is there, or a wound is there, or a swelling is there, or a growth is there. He can never utter the word of ulcer-proliferative growth, isn't it?
Okay, sir.
So complaint should be
not
always
use
the
that.
patient's own words.
Can you go back to your slide, previous slides?
Yes, sir.
Yes. Okay.
But now, Kanna sir, what we normally now expecting the student, but the chief complaint should be in the language of the patient. But the complaints, present illness, when he is saying it is better, he is explaining in some mixed scientific language. And if it is purely on the patient language, it will be difficult to explain the total thing. And chief complaints will be in the language of the patient, and the present illness can be in the scientific term.
The chief complaint has to be in the patient's language, isn't it?
That is absolute. Chief complaint has to be in the language of the patient.
Yeah, so he cannot say it's ulcer, because
Yeah,
I'm pretty sure that many of the even the students will not know that what is ulcer-proliferative growth.
Definitely.
Yeah, so that should not be there. And what type of trauma you are interested in?
Suresh, sir, you are muted, sir. Sorry, sir, please carry on.
What type of the trauma you are interested? You said there is no history of trauma.
Yes, sir. Any trauma, it might be any traumatic ulcer to rule out that.
What type of the trauma? External injury, somebody hitting the oral cavity?
Following a sharp tooth, there may develop a constant pinch over the inner aspect.
So abnormal dentures.
Yes.
Or yes. So that is the trauma there you are expecting.
Yes, sir.
Balaji.
You said the patient is taking the betel nut 10
Yes, sir.
to 12 packs per day. What does that mean? 10 to 12 packs per day?
The betel nuts usually comes here in packs, sir. He is consuming around 12 packs per day.
Balaji.
So
Yes,
from
ma'am.
one pack, he will make one
Am I
quid.
audible?
From
He's
one
not-
pack, will he make
Yes.
one quid?
He's not actually making quits, sir. Just a 4 or 5 pieces of betel nuts in a pack is available, and he's chewing them.
Is it a betel nut or kutka?
Betel nut only, sir.
And where he was keeping that quid or whatever you say?
Yes, sir.
Was he keeping this overnight, or
No,
he was
sir.
only taking the daytime?
No, sir. He is throughout the course of the day, he is chewing them, sir.
Okay.
Balaji, you
Yes,
have
ma'am.
mentioned that this patient has pain is not referred to ear. Do you think
Yes,
the
ma'am.
pain from the lip can be referred to ear? What is the pathway?
Ma'am, if there is any lingual nerve involved, it may be transmitted through the auriculotemporal nerve and he may have ear pain.
Where does the lingual nerve come in relation with the lip? It comes in
Usually-
relation with the tongue only, right?
Yes, ma'am. In tongue lesions, it might be present.
So
You have
for
already
that,
said floor of the mouth is not involved.
Yes, sir.
So in that case, I think you need not ask about pain getting referred to the ear.
Okay, ma'am.
And you said this patient has got no excessive salivation, but he has got some chewing disturbance, you said.
Yes, ma'am.
I thought of some chewing disturbances. Definitely he'll be having the salivation. There would be some amount of drooling which should be there. Okay, with such a big lesion which is present in the outside the oral cavity,
Yes,
he will
ma'am.
not be able to swallow his own saliva. Definitely there should be some amount of drooling which should be happening. Though it might not be excessive, but there should be some drooling which has to be mentioned, right?
Okay, ma'am. Yes.
Dr. Balaji, can you go
Balaji.
back to the second
Yes.
slide?
And
Yes,
you said
sir.
there is no difficulty in speech. Are you sure there was no difficulty in speech when you don't have a low lip to articulate? Do you think the speech would be normal? Was it okay? Or there was some
Speech-
slurring?
No, ma'am. It's quite normal compared to.
It cannot be normal, Balaji, unless you close the mouth completely. The certain words cannot be told. So definitely there will be some difficulty in speech will be there. You said there is difficulty in chewing, but
Yes.
no difficulty in swallowing. What are the phases of swallowing? What are the phases of swallowing? Swallowing, it starts from chewing itself.
Yes, sir.
Even your mouth, when there is a mixing up in the mouth, that's also oral phase. So you
Okay.
have a oral phase, you have a pharyngeal phase, and you have a esophageal phase. So
Yes.
when you say chewing is abnormal, you cannot say swallowing is normal. That means
Okay.
your oral phase is. One more very obviously you are using the word insidious. Please, that word you need to use very cautiously. Even the pain you are using insidious. The insidious not only means gradual onset, but patient is not aware of that. Something is happening without the knowledge of the patient. Suddenly we are seeing at the last stage. So
Okay, sir.
it is not better to use insidious in the pain and other things.
Okay, sir.
Balaji, you said also no history of hoarseness of voice.
Yes, sir.
What is the reason for asking this symptom?
Sir, any synchronous other primary lesion for ruling out any recurrent laryngeal nerve palsy involvement, laryngeal malignancy to rule out.
The leaf malignancy and which other malignancy synchronized, which can cause hoarseness of voice.
Yes.
Because he is having a history of betel nut. There is no tobacco.
Sir?
He's using betel nut only.
Yes, sir. Yes, sir.
Can I sir look into the voices because it is totally disturbing.
Yes, yes.
Balaji.
Yes, sir.
Good evening.
Good evening.
Is the ulcer at the site where he uses the keeps the betel nut, or is it?
Yes, sir.
Is there a particular site where he keeps the betel nut and he gets this?
He initially starts chewing over the floor of the mouth and lips are actively involved in it, sir.
So, do you think this chewing of betel nut could be a cause of his carcinoma of the lip?
Yes, sir. It can be implicated in this, sir.
Wouldn't the floor of the mouth be more commonly affected than the lip?
Floor of mouth is common than the lips usually, sir.
No, I mean, had he been smoking, then I would have expected that site to be affected with cancer. But if he's just using betel nut,
getting a lip affected is very rare.
Right.
Yes.
Also, what do you think is there in betel nut which causes cancer? What is the active ingredient there? And why does it happen? What is the betel nut called in English?
In any other nut starts with A.
Areca nut.
Areca. So what is the ingredient there? You just expand on it.
Arecolin.
Same word you can use. Yeah.
Arecolin. Very good. So how does it act? How does it affect the lip? How does it affect the patient causing malignancy?
So this carcinogen causes frequent irritation of the mucosa over the lips, sir. And it makes the mucosa vulnerable to further genetic changes. And if it's
genetic changes, you think
yes.
genetic changes will not happen?
If the patient is predisposed,
No. Further,
Actually,
if you are taking a smoke, everything, alcohol, all this
yes.
can act on that.
Right, they cause vasospasms, and these alkaloids, they cause dysplastic changes, right?
Yes, sir.
And what is field cancerization then?
Sir, field cancerization refers to the existence of even a similar malignancy in the upper aerodigestive tract concurrence with the primary lesion, sir.
Okay, there can be malignancy or there can be just dysplastic changes. It's not necessary that
yes,
there will be
there
malignancy.
Might be dysplastic changes, and if there is any exposure, it can trigger a potential malignancy in the tract, sir.
So, so you think the change in voice, which you said,
yes, sir.
And difficulty in swallowing, I don't remember exactly. Could it be because of some other malignancy in the oral cavity? Because I'm not getting I'm not being able to join areca nut with CA of the lip.
Okay, sir.
What are the other predisposing factors, bro? Carcinoma lip?
Yeah.
Usually sun exposure, sir.
But you are not talked about that, whether he is openly working with a field worker. So all
He's
that
a
is
daily
more
wager,
important.
sir.
No, daily wager can be work in the house
What kind of
also,
a work
inside the
he's
house.
doing?
No, sir, he works in the field only, sir.
So that you should mention.
That is
That is the
important.
most
That is the
important.
important thing. How long he's being exposed to the sun?
Yes, ma'am.
That has to be mentioned.
Okay, ma'am.
Okay.
Yes.
But sometimes this no history, when you are writing, be careful, because once you are written here, no cough with expectoration, then you are going and saying no hemoptysis. Once you said no cough, how can you expect a hemoptysis to be there? So these, I mean, as a PG, when you are presenting, certain words should be little more careful. You present in a way that you are presenting with the confidence. So most important risk factor you should be highlighting more than going on a pack index, which is nothing scientifically, no textbook is saying about the pack size of the betel nut.
Okay, sir.
We do not know which pack which they are using. So you should have given little more clearance than saying a pack, how many packs, all those details.
Yes, sir.
Balaji,
yes, sir.
You have been telling that there is no history of radiating and no history of referred. Could you tell what is the difference between the radiating and referred pain?
Radiating pain is usually starts at the site of the lesion and it gradually ascends to another site, sir. Migrates to another site.
So migrate?
Sorry, radiates in the to be precise.
Referred pain means?
Referred pain, if we know the site of the lesion and if we suspect a nerve to be involved, that in that referred pain may be at the distant site which is applied by similar nerve, sir.
Okay. So could
what
you tell
similar? What do you mean by similar nerve?
That now progressive nerve course, sir, which gets the fibers from that.
Balaji, it would be nice if you gave an example of migrating pain and referred pain and radiating pain. That would make your job much easier and tell the examiner that you know about it. Okay.
Yes, sir.
Radiation pain, as the disease progress, the pain is also progressing. It is the disease extension of the disease it is going. Referred pain, the afferent and efferent nerves are different, but from the same root value.
Yes.
So it has an afferent nerve is taken to the one nerve, but the efferent effect is coming through another nerve. but both have the same root value. So that
Yes.
is how it is meant referred pain. That is why we have a ear pain. We have got, because all other structures can go to the ear. There are 5 nerves are there, you can go. But lips, we don't normally expect a referred pain.
Okay, sir.
Is there any clinical significance of this referred pain or radiating pain?
It says the disease is advanced.
Yeah, very good. It's likely to be an advanced deep infiltration. So, okay. Yeah, proceed.
Yes, sir.
Yeah, go to examination.
Yes, sir. Coming to the examination part, the patient is conscious oriented. He is moderately built and nourished with hydration fair. There is no pallor, icterus, clubbing or cyanosis, no pedal edema or generalized lymphadenopathy. His vitals are stable. Coming to the local examination part, this is the clinical pictograph of the patient. On inspection, I could see 8 cross 4 centimeters ulceroproliferative growth over the lower lip, extending almost the entire length with well-defined margins and everted edges. There isn't any active bleed or discharge from them. I could note a poor oral hygiene, dental caries with loose tooth. The commissures were normal. Gums, alveoli and buccal mucosa seem to be normal. Flora of mouth was found normal. Mobility of the tongue was not restricted. The uvula was in midline. Retromolar trigone and both the palates were normal. And coming to his dentition, upper jaw, the left was 2, 1, 2, 3. There was loss of last 2 molar tooths in the left upper jaw, and with the loss of single tooth in the right upper jaw. And the lower jaw, there is a single premolar tooth lost in the left lower jaw, and all the 3 molars are absent in the left lower jaw. In the right side, all 3 molars are absent in the lower jaw. Coming to the palpatory part, the on palpation, the ulcerative growth is not warm, not tender. The inspectory findings of site shape and extent are confirmed. It was hard in consistency. It doesn't bleed on touch. The base seemed to be indurated. Mandible on palpation, there's no any thickening or irregularity. There wasn't any trismus. And coming to the examination of neck nodes, multiple small nodes are palpable in bilateral, submental, and the submandibular region. The nodes were mobile with firm to hard in consistency, and they were with smooth surface and non-tender, and skin over the node swelling were normal. And systemic examination, there wasn't any significant abnormality and found to be normal. And coming to my diagnosis part, the patient is a case of carcinoma of lip involving the entire lower lip with bilateral level 1A and 1B cervical lymphadenopathy with a TNM staging of T4 N2C MX, which is a stage 4 disease.
Coming from your picture,
Yes,
I find that the commissure on the right side
Is
lip is going to
involved.
be involved. Okay, you said that the
Definitely.
commissures are not involved. And obviously there is a bleeding which can be seen on your picture. And you say there is no bleeding. And how did you examine for loose tooth on your inspection? And why do you want to talk about mobility of the tongue is not restricted again in a person with a lip cancer, which has not gone further below?
Yes.
Okay, these things can be avoided.
Okay.
Or you need to take a little more care when you're going to present when these things, right?
Yes,
But because you are giving a picture and saying commissioner is not involved, that is very obviously there is a involvement is there. And in the palpation, you said not warmth, not tender. How did you made out? Ulcer is not warm, not tender. It's a painful ulcer. But in the palpation, you have started your finding with not warm, not tender.
Palpation, it's not tender, sir.
No, not warmth. How did you felt the warmthness of the ulcer?
Yes.
Any given ulcer, we can't look for the warmth over the ulcer. Only the surrounding areas might be warm. Okay.
It doesn't make sense. It doesn't make sense. I mean,
Right, we don't talk
okay.
about the ulcer, whether it is warm or not.
We never going to get that. So certain things not necessary for the PG when you are presenting, not as a routine.
Okay.
And your picture you are saying, as Madam has rightly said, it's obvious bleeding point we are seeing. But you are saying there is no bleeds on.
Okay, sir.
And the history said no tooth extraction, but it says a lot of tooth is missing. That is
Sir, it's
fallen or
fallen accidentally, sir. Yes, sir. Close to.
you said
Balaji?
base is indurated.
What?
What is the
Yes.
level of induration? What do you think?
Induration, yes.
Induration, sir.
What is the
How do you
extent
make
of
out the
induration?
Induration seems to be about almost up to 1 centimeter, sir.
Where? In the lip.
Sir, from the region where I could palpate the margins, sir, up to depth of the base.
Balaji,
Yes, sir.
now you said that there are lymph nodes involved.
Yes, sir.
Right. So what is the minimum depth of an ulcer, malignant ulcer, which will lead to cervical lymph nodes?
Depth of invasion, minimum 5 mm might be present if there is a lymph node.
If it was involved, we can be sure that it is more than. Yes, very good. It is 5 mm. More than 5 mm, if the ulcer is involving the depth, the chances of lymph nodes is very high.
Yes, sir.
And do you think the alveolus was involved or not involved?
Alveolus is not involved, sir.
Was the alveolus involved?
What, sir? Pardon, sir?
No, that's fine. I thought because it looks, the picture is like.
It's very near to
Will
the
it make a
alveolus.
difference if the alveolus in your management, if the alveolus is involved?
Sir, alveolus was clear only, sir.
So the
Balaji.
induration was not extending into the alveolus?
No, sir.
Okay.
Balaji,
Yes.
so you told that invasion is more than 5 mm. You have a
Yes.
chance of invasion. How will you measure this invasion? Did you measure, what do you mean by tumor thickness and the depth of invasion?
Especially in ulceroproliferative lesion, how do you see the invasion?
Invasion,
Or how will you measure invasion? It is a clinical or pathological?
pathological, sir.
So, okay,
Most
how
of
will
the-
you measure? What is the measurement you will see? It is from the basement membrane. It is not the tumor thickness, which is called as a depth of invasion. Tumor thickness is totally different, and the depth of invasion is totally different. Depth of invasion is measured from the basement membrane, and how it is measured in 5 mm. Is it any significance? As sir
Yes, sir.
told,
Yes, sir. Depth of invasion is important. If the depth of involvement is significant, we need post-op radiotherapy.
no. See, that I understand. This depth of invasion is very much significant because previously in a TNM staging, there
Yes,
is
sir.
no need
In
of depth of invasion. Now, in a
the
recent AJCC 8,
AJCC,
we
yes,
have
sir.
been added because it's very important prognostic, and our treatment plan is also based on the depth of invasion, and the patient outcome is also based on the depth
Yes.
of invasion. Okay, so
Yes, sir.
yeah, proceed.
What is the other change which has been made in recent AJCC 8th edition?
The extracapsular nodal spread is made.
So
Do
clinically,
you
what
mean
should
with
we
that
look
extra
for?
capsular, or what is the term exactly used in AJCC? It is not an extra capsular, it is an extra nodal extension.
Extranodal extension.
ENE. Okay,
Yes.
the extra capsular, it has been used, but presently in AJCC, ENE. Okay.
Yes. Yes, sir.
Balaji,
So can you identify that there's going to be external extension clinically?
Sometimes it can be made as gross. Yes.
No. When looking at the node palpating, can you say whether there is an extranodal extension?
If the node is fixed to underlying structures infiltrating, we can comment as extranodal extensions.
Even mapping, even if it is adhered to the other structures, also there is
If the nodes are
not only
adhered
the
to each
fixing.
other.
Yes.
Skin involvement and fascia involvement, underlying structure,
Yes.
we can make out. Okay.
Yes, sir.
You have put this as a T4 lesion, no, Balaji? Why you have
Yes.
put as a T4 lesion here? What made you to think of T4?
Yes, sir. In the latest AJCC edition 8, up to
Yeah.
tumor centimeter 6 centimeters only classified as T3, sir.
No, there is no classification like that. But T4A very specifically given only when the particle bone is involved or that alveolar nerve is involved.
And you are not mentioned whether it is T4A or T4B. You just mentioned T4. When you are qualifying T4, why do you make it it's a T4? What made you to quote as a T4?
What is the evidence you have to say it is a T4 clinically? You said mandible is free. So cortex, mandible is not involved. Floor
Yes,
of the
sir.
mouth is not involved.
Yes, sir.
The skin is not involved. Pain, nerval is also not. There is no obvious involvement. Inferior alveolar nerve is not there.
Yes,
So
sir.
that makes it is only a T3.
Based on the size I found in the TNM staging, I quoted as T4, sir.
No, always refer NCCC or AJCC direct. There is nowhere it is. I think Dr. Suresh Kumar sir can.
No, sir. Based on T3 is not based on the size. T4 is not based on the size. As I clearly mentioned, T4A, the involvement of the cortical bone, nerve involvement, skin involvement. T4B, as we say, the oral cavity per se, involvement of the carotid, deep cervical fascia. The T4A is an operable advanced disease. T4B is inoperable advanced disease. And it is not mentioned according to the size, T4.
Sir, according to 2022 NCCN version, T4A states that if the size of the tumor is going to be more than 4 centimeter, it comes under T4.
Madam, NCCN will not give either UJCC or AJCC recommend the staging.
Yes,
NCCN is a guideline.
Sir.
Yeah, guidelines. NCCN is a
Guidelines says
guidelines.
that tumor more than 4 centimeter.
No, madam. AJCC is only coming. 22, there is no AJCC has come.
8th edition only.
Okay, 20. Okay, NCCN 22, which shows AJCC more than 4 centimeter, but the depth of invasion, they say when it's more than 10 mm, then.
That is T3, madam.
Pathological.
That is T3. T4A is separate. T4A is only a cortical bone involvement.
Okay, sir.
And inferior alveolar involvement.
Right. But I think with the size he has mentioned, I think more than 4. That's what he thought in terms of.
Dr. Balaji, can you go to the slide of lymph node examination?
Yes, sir.
Yes. This is a form 2 hard inconsistency means which consistency you want to say? Because hard is different diagnosis, form will be having a different
Yes, sir.
diagnosis.
Some notes were firm and some were hard, sir. Variable notes.
Okay. And what are the size of this lymph node?
Significant weight loss along with weight loss.
Size of this lymph node?
Most are very small, sir. Around 0.5 to 1 centimeter nodes only, sir.
So how can you say it is clinic TNM T2 when they are not significantly enlarged?
No, that is sir. The problem, I think that Dr. Suresh Kumar sir, you can a little clarify on that because N2A is 3 to 6 centimeter nodule, but N2B it is any node, multiple node less than 6
bilateral.
Even if there is a 2 nodes of more than 1 centimeter, it has to come under N2B.
Yes, sir.
No, Suresh Kumar sir.
Yes, sir, you're correct,
No, what
sir.
Where is
NTC is correct. When you have
N2A is 3 to 6 centimeter node, less than 6 centimeter. But N2B, it comes to multiple nodes less than 6 centimeters. So even if you have 1 centimeter node, 2 nodes, so that makes N2B. So that is why he has put us.
See, generally, N2A, B, C, what we see is N2A is more than 3 centimeter, less than 6 centimeter, single node. And N2B is multiple node more than 6, none more than 6 centimeter. None more than 6, all are 6 centimeter. And
so even if
C
you have
is,
2 nodes less than around 1 centimeter size, it will come under.
Yeah, it will be an N2B. And bilateral or contralateral, then it less than 6 centimeter, it comes as N2C.
That is absolutely. No, but there, I mean, what I personally I feel there should be some more clarity on that. N2A, let's say to more than 3 centimeter node, we are saying less than 6 centimeter N2, even if the 2 nodes are just 1 centimeter, it will make N2B. So, what you are going to do, Balaji?
Sir, I would like to proceed with the investigations first. Investigation part, coming to routine investigations, we have the blood investigation and general workup for a surgery or a radiation, followed by specific investigations which involve the edge biopsy of the ulcer for a pathological confirmation of the diagnosis, and we do a ultrasound neck to look for the nodal status, and we will proceed to the FNAC if we suspect it's a malignant node. Also, for a local regional evaluation, we do a CT scan and MRI scan.
कंफर्म कर दिया था उसके यहाँ वो नहीं था.
I think today is a lot of. So you want to do all USG, CT, MRI.
MRI
In the present, in a given case, what do you want to do? How you are planning? What is your plan of management? Just first you have to confirm your diagnosis.
Yes,
so what do you want to do?
So edge biopsy of the ulcer.
Okay. Then you have to see the extent of the disease.
Yes.
So how you are going to see the extent? What are all the investigation modality available to see your extent of the disease?
CT and MRI are available.
No, MRI, which you will go. Everything is available.
I will go with MRI, sir.
Okay.
Why you prefer MRI over CT scan?
MRI is better in terms of compared to CT, sir. Soft
what
tissue
way?
infiltration.
Okay.
An extent of the disease can be better delineated by MRI.
Okay. If you want to assess the bone involvement, do you prefer MRI or CT scan?
Bone infiltration, usually CT is better compared to MRI, sir.
Okay.
Suppose bone medulla is involved.
Marrow involvement.
Marrow is involved. Marrow involvement.
That is picked up by MRI again, sir.
Okay. Okay. So
in this case, is more percent MRI.
Yes, sir.
See, this oral cavity, lip lesion,
yes,
clinically sir, you can easily assess. So, do you really need an imaging modality? Because you are told it is confined only to the lip, and as per your clinical examination, you doesn't have any bone involvement, any adjacent structure involvement. So, or you want to just go with the biopsy, or you need definitely you want to go for a investigation, imaging modality.
Imaging is still needed, sir.
Why?
To pick up
when you are asked, see, when you are asking any investigation, it should either support or it may change your treatment plan. In what way your image is going to change your treatment plan, particularly for this case. Because I have not seen, only the picture you have seen. As per your this thing, it's only confined to the lip, lower lip. Yes. And you have clearly told alveolus, everything ridge, everything is not involved. Do you still more you need an investigation, imaging?
Yes, sir.
What is the distance between the inner limit and the alveolus in your case?
It's roughly 0.3 to 0.5 centimeters. Very close.
So in that case?
Yeah, you can substantiate your clinical findings. It is very close to the bone margin. I just want to see it. See, you have to come out with your justification. Okay, when you ask something, what for you are asking, you have to come out. As madam clearly give the clue for you that what is the distance. So to make sure that there is no underlying bone involvement, I just want to go for the further investigation. And you told that FNAC of the lymph node. Is it routinely used for all the cases?
No, sir.
FNAC is mandatory. Then
No,
why
sir.
did you say? In an head and neck malignancy, how the FNAC is going to alter your treatment? Are you going to change or are you going to plan your treatment based on FNAC?
Sometimes there may be a reactive.
Okay, suppose positive, well and good. If negative, what you are going to do?
The level of neck dissection might vary, sir.
Based on the FNAC.
If it's only
Yeah, I don't-
reactive nodes,
Such a
No,
big
no,
lesion, you are not going to go for the lymph node dissection if FNAC is negative.
See, generally in an head and neck malignancy, we won't advise any FNAC of the node. Okay. See, irrespective of thing, when you are planning for a surgery, you need to address the neck node in an N0 to stage the disease.
yes.
Okay. Only except in very early cheek lesion or very early lip lesion. But this lesion, which is very, as you say, T4 lesion, you need to definitely address the neck node, either it selective neck dissection or a comprehensive neck dissection. That will come to later. Okay. So FNAC, definitely I don't agree with this. Okay. Okay. So you're done biopsy. It comes as a squamous cell carcinoma. And MRI or whatever, it's confined to the lower lip.
Yes.
So then what do you want to do?
If it's without any adjacent structure infiltration, we can go with the surgery, sir.
No. See, okay. So you want directly planned. See, do you need to do any metastatic workup? Because you confirm and you see the extent of the disease.
Yes.
You want to see the metastatic workup? But you didn't say anything about that.
For a metastatic workup, CT chest may be done.
CT chest.
It is not maybe done. You go by the
Has to
very
be done.
definite order.
Okay.
It has.
And one more thing, you told that there's some field cancerization.
Yes, sir.
Okay.
The
So
upper
do you need to see other part of the upper aerodigestive?
Yes, sir. Pan endoscopy is to be done before proceeding surgeries.
No, not pan endoscopy. Okay, so you need, so this thing has to be in head and neck cancer. You need to evaluate the field cancerization as well as the generally as a part of field cancer, lung cancer is more involved. Yes. So you need to do minimum of chest X-ray or a CT scan depending upon the institute policy. Okay, yes. So and field cancerization, you are supposed to evaluate the upper aerodigestive. And usually it's called DLDP, direct laryngoscopy, and esophagus up to OG junction. Okay, yes, this is routinely recommended. Okay. Next. Okay, now you told that you want to do surgery. I am deferring. Why not radiation? Why do you choose surgery?
You decide or you subject the patient to tumor board?
Balaji, tell how you are going to decide.
Seems to be operable, sir, without any major deep structures involvement.
Okay.
Balaji,
so
understand the
operable
question.
means,
What is Jailal sir asking? Whether you will decide or will refer the patient to the tumor board?
We'll get a surgical oncologist opinion. We will decide.
So it's not that surgical on tumor board means surgical, radiation, medical oncologist, pathologist, and radiologist, and other treating physician also. It is not that surgical oncologist alone. Okay.
In the examination, it is safer side to say I will discuss with the tumor board, and there you can say your point. What you want to can be expressed even in the tumor board. But better go through a procedure system we need to follow. In them.
And you say surgery. So why do you want to prefer surgery? See, why do you want to prefer surgery? What surgery you are going to plan?
It's almost entire lip is involved.
Yes, sir.
You can just remove it. That is different. But you have to think about its function.
Reconstruction is needed.
So you have to think about that. Say that's why you have to think collectively.
Yes, sir.
So now you tell me, you have an option, what you want to do and why you choose one over the other.
Surgery, the lesion seems to be clinically as well as investigation wise operable stage, sir.
So when you say it is inoperable,
Inoperable.
now it is. Now you come.
When
So you say it is
inoperable.
operable. When you say it is inoperable.
If it's a 4B, very advanced stage,
Okay.
involving the skull base or the surrounding structure, bony involvement.
Yeah, obviously any head and neck, skull base, carotid, and vertebral fascia involvement is contraindicated. But locally, when you say it is inoperable, technically, you can say, you see, madam has clearly pointed, you have to remove the one commissure. Okay. Yes. When you have to give a margin, okay, and you see 1 centimeter, you will give margin. An entire or lip will be go. So you have to do what kind of reconstruction you will consider?
Free flap transfer we have to do. For
yeah, free flap is the ideal way. And what will be the function? How the function patient will have a functional outcome. Okay.
Main activity is a function. That's closure. The leaking should be avoided.
Yes.
Okay, the aim is not that doing the surgery is we have to come out with the good functional outcome also. Okay, yes, so all put together, we have to choose the treatment. So this big, and one more thing, as we should know that this is a proliferative growth of. Yes, sir. Sometimes it may be very well controlled with radiation also. See, generally the radiation will have very good effect in the proliferative component. Component only, there will be a problem. Okay, this patient, that's an option of radiation also. So being a surgeon or going to be a surgical oncologist, definitely you'll prefer. That is a different point. Okay.
Yes, sir.
So T1, T2, you will be justified saying more oversized surgery. But when there's a T3, T4 lesion, radiotherapy also plays a major role. Okay. Don't straight away jumping into that, and that, especially squamous cell carcinoma with the proliferative growth, the response rate is going to be very good.
Yes. Okay. See, now as sir clearly pointed out, T1, T2, early stage, single modality of treatment is more than enough, either a surgery or a radiation, depending situation where is the lesion placed. But when it comes to T3 or T4, it is a multi-modality treatment. Yes. Where radiation, surgery, chemo is definitely involved. Here, the problem is the sequencing. Okay, the sequencing is whether to do radiation followed by surgery or surgery followed by radiation. Here it comes very important. You have to choose because the idea is to get a negative margin. So when you feel that, as you say, I'm able to get a good negative margin, I can able to reconstruct with the good functional outcome. Yeah, go ahead with the surgery, then followed by radiation. If you feel that you cannot get a negative margin, you may give a chemo radiation as an initial down stage, then resect and reconstruct, so that the outcome will be better. Is there any difference in this treatment plan? In outcome basis, either surgery followed by radiation or radiation followed by surgery?
Radiation followed by surgery is better for functional outcome.
No, it's not like that. Both are equally effective only, more or less. Okay, the only thing is it makes easier for the surgeon and for the reconstruction part also. Okay.
Yes.
So what you are going to do for the node?
Yeah.
Node here in this case, level 1A and 1B are involved, sir. If when we operate, it's better to go with bilateral supraomoid dissection.
What is supraomoid dissection?
Selective neck dissection involving removal of level 1 to level 3 nodes, sir.
Okay. Why you are confining only to supraomoid? When will you do extended supraomoid?
Normally, supraomoid is for when there's a N0 lesion. When we have a T3, T4, with the N0 lesion, you can do.
Yes.
When there is a node is there in oral cancer, I mean squamous cell carcinoma, it is always better to do radical node dissection.
Yes, sir.
Yeah, Balaji, tell me,
Yes.
what is the difference between the supraomoid and extended supraomoid? When will you do supraomoid? When will you do extended supraomoid?
For extended supraomoid, if there is involvement of any other adjacent structures to nodes.
No. See, as oral cavity generally drain into the level 1, 2, and
Yes.
3.
Yes.
Okay, that is the common drainage area. Except in the tongue, you'll have an
Acquisition.
level 4 is also involved. It is almost 16%. It may be a skipped metastasis also.
Yes,
For that particular reason, in a tongue, we have to go for an extended supraomoid neck dissection, which includes level 1 to 4. Okay.
Yes.
So for N0 neck, you need to address bilateral supraomoid.
Supraomoid.
Okay. So will you do frozen section or you just do only supraomoid and you'll come back? Because supraomoid is like a staging. Okay.
Yes, sir.
It's a therapeutic or it is a diagnostic.
Sorry, for N0 we can complete with the supraomoid, sir. It's therapeutic.
Okay. Suppose you do supraomoid. Okay.
Yes, sir.
The histopathology will come as a positive node. Then
Yes,
what
sir.
will you do?
Positive nodes, adjuvant radiotherapy can be given post-operatively.
Okay. Or any other option?
That's why sir asked you if the frozen section facility is there, so you are on the field. Frozen section is coming as a positive.
See, as sir clearly told, if the frozen section is available, it's not mandatory. If available, use it. If positive, you convert that supraomoid or selective into a comprehensive or radical neck dissection according to the comprehensive neck dissection. We generally don't call radical. It's a comprehensive neck dissection based on the thing we decide. Type 1, MRND 1 or 2 or 3 we decided. Okay. So if not available, as you say, either you can go for completion of the neck dissection or you can treat with radiation, depending upon the number of nodes and as we say extracapsular disease like that. If it is present, then we will do it. Okay. So I think Sarah has told to conclude this case.
This section, are you planning to do it unilateral or bilateral?
He told bilateral, madam.
Bilateral.
Okay. Good. All the best.
MRND3 and functional neck node dissection are same.
Functional neck dissection refers to any MRND, sir, and it has 3 types depending on the preserved structures.
No.
Radical neck
dissection. Sir, question is very clear. MRND type 3 and functional dissection is functional neck dissection are same or not?
Same or not?
Same.
When
You
you do
preserve all the
functional
3
neck
structures.
dissection? Balaji,
in N0.
so when will you do? No,
Yes,
when
sir.
will you do a functional neck dissection?
So commonly in your practice, in your ward, where you do the functional neck dissection. Functional neck node dissection we do only for
Thyroid.
in thyroid malignancy.
Thyroid, medullary.
No,
Will
thyroid
you remove the level
malignancy.
1 node? Will you remove level 1 node in the thyroid malignancy?
Yes.
No, you are not, man. You won't remove. What is the difference between, as I told clearly? See, you will not remove the level 1 node. And one more thing is the supraclavicular nodes, the subcutaneous supraclavicular nodes, that also will be preserved in the functional neck dissection. Okay, in MRND, we will remove all the things. Okay.
Okay.
So the ideal word now better comprehensive neck node dissection. So you say that and then describe that what is the difference.
Yes, sir.
So you
good.
presented well.
If you do the excisional surgery in this patient, how you are going to reconstruct the lip?
Free flap transfer is better for this patient, sir. Usually the radial forearm free flap is preferred.
But can you use any loco-regional flap for full lip reconstruction?
Whole lip, it's difficult from loco-regional aspects, sir. The wide defect has to be covered.
No, free flaps are nowadays okay. Previously, what used to do?
You can use the forehead flap. You know, forehead
Oh,
flap is a good flap which can be used, or you can use the bilateral nasolabial flaps, bilateral. That
okay,
can
sir.
make the lower lip, you know, complete lower lip.
Yes, sir.
Okay, if you are giving the radiation to this patient, what type of the radiotherapy you are going to give?
External beam radiotherapy.
You know, for the oral cancers, what are the other types of radiotherapy you can give?
Sir, currently, radiofractionation technique is getting popular. Hyperfractionation therapy.
No,
The
no, no.
radiation-
See,
That is the external beam,
we-
isn't it? Yeah.
so sir is asking the type. It's
You
not
know
a
the
fraction.
you know the brachytherapy?
Yes, sir.
What is brachytherapy?
Brachytherapy is localized to the tumor, sir. Application of radiotherapy to the localized structure.
How do they
So
give?
can you use the brachytherapy in this patient? And if you can use it, what type of the brachytherapy it will be?
Brachytherapy is delivered by devices fixed to the local part, sir.
So you can put the needles there. You know, that is the interstitial type of the radiation. Okay, interstitial type of radiation.
Yes, sir.
Like in cancer
So
of the penis or in the cancer of the cervix, you can put the mold there. You know? Mold radiotherapy can be put, but like in breast cancer also, if you are doing the breast conservation surgery, you can put the tubes there, and through that you can give the interstitial radiotherapy to the patient. Okay.
Okay, sir.
Balaji, since Sarah asked, what is the advantage of brachy over the EBRT?
Brachy, it's confined to the lesion, sir. So other sites are prevented from radiation exposure, which might trigger a
Good.
secondary lesion.
Yeah, you can deliver a maximum dose to the tumor vicinity, and simultaneously you can avoid the radiation toxicity to the adjacent area. Okay.
Yes.
You know, which is the latest modality which is there for the radiotherapy? Any idea?
Intensity modulated radiotherapy.
Proton therapy. You know?
Proton, yes.
So you know what is the advantage of proton therapy?
Proton. Not sir.
The biggest advantage of proton therapy is that, like, if you give the radiation from one side, it will go to the tumor bed. Normally, all these radiation which are there, they will exit from the other side. But in the case of proton, it doesn't exit from the other side.
Okay, sir.
The other side surrounding tissue which is there, it will be not affected by this radiation here. So that is the biggest advantage. But proton therapy is a very expensive therapy. So I think in India, probably it's available only at one center. And the cost for the proton therapy is around 30 lakhs.
Okay.
It's a very expensive and not available commonly. Okay. Yeah.
Okay.
Yeah.
Asit Patel, sir, do you have any questions, sir?
Hello.
Yes, sir.
Yes, sir.
Do you have any comments or questions, sir?
No, sir. He has done very good homework and he has presented well. He has answered most of the questions.
Yes, sir. Bala, you have any questions or any clarifications from the faculty, ma?
Yes, sir. Regarding the planning for surgery versus radiotherapy in T3 lesions, sir, which is
What is
preferable?
your doubt? What is your doubt?
Sir, which is better to be done first, sir?
No, as I told clearly, it depends upon the lesions. See, as I told, T3 and T4 multimodality. It means that you need to give radiation, you need to give surgery, you need to do surgery. Okay. So how do you choose? Depending upon the lesion. Okay. See, if the surgeon is very comfortable with, he can resect with the negative margin and simultaneously he can give an adequate functional outcome, then we can go ahead with surgery. And preferably surgery followed by radiation will have a better outcome. Being a surgical oncologist, obviously I will say that. But my thing is, I have to give a negative margin. If I compromised in that, and you should know that, see, inadequate surgery, see, radiation or chemotherapy is not a substitute for inadequate surgery. This is the dictum. Okay. Something you do and it cannot be tackled by radiation, or it is used as an adjuvant. Okay. So you have to plan, and you have it based typically depends upon the lesion. Okay, it is not that fixed that all patients should go to radiation. See, even T4A or T4A lesions sometimes focally involved, you can go with surgery. Okay, and followed by radiotherapy. But if you have a diffuse edema is there, if you feel that there will be some margin positivity there, then you have to consider radiation to downsize and to reduce the tumor burden, then you have to consider. So it is not that all the T3, T4 lesion, either way, depending upon the situations. Okay. The thing you should know is it's a multimodality. How you are going to choose, as sir clearly told, it's a tumor board. All the people sit together and decide on. Okay.
Yes, sir. Okay, sir. Thank you.
Thank you, Bala. Thank you for joining this.
Thank you very much.
I thank the faculty for the first case. Then we move on to the next case. This is kindly contributed by Professor Srinivasan sir from Coimbatore. Karthi, are you with us?
Thank you, sir.
Thank you, Bala.
Sir. Yes, sir, I'm here, sir.
Can you start? Bala, can you unshare your screen, Bala?
Yes, sir. Done, sir.
Yeah, thank you. You can also stay with us.
Sure, sir.
Karthi, you please start your PowerPoint.
Yes, sir, I'm on it. Am I visible, sir?
You are fine,
Yeah,
ma. Good luck to you.
Yes, sir. Myself, Dr. Karthikeyan, second year MS postgraduate from Coimbatore Medical College under the guidance of Dr. Lakshmi Narayani, HOD of Department of General Surgery, and Dr. T. Srinivasan, Professor of Surgery in Coimbatore Medical College. I present you all the case of parotid swelling, and I welcome all the estimate faculty and visitors as well. We have a case of 60-year-old gentleman coming from Tirupur, is a driver by occupation belonging to a low socioeconomic class status, and he presented with a swelling below and in front of the right earlobe for the past 1 year. The patient was apparently normal, actually 3 years, sorry, the patient was apparently normal 3 years back, following which he noticed a small swelling below and in front of the right earlobe. It was insidious in onset, initially small and gradually progressed to reach the current size, and he did not have any pain over the swelling. No history of rapid increase in the size of the swelling, no history of fever, no history of any variation in size or pain while the patient was taking food, no history of any purulent discharge into the oral cavity, no history of any other swelling in the left side of the parotid region and in the neck region, no history suggestive of facial nerve palsy or seen, no history of loss of appetite or loss of weight, no history of dryness of eyes or joint pain. Past history, patient does not have any comorbidities such as diabetes or hypertension. He does not have any history of previous surgeries, no history of mumps or no history of radiation exposure, and no history of previous malignancy or radiation treatment. Personal history, he takes a mixed diet. He is a known smoker for the past 15 years, takes 1 pack per day. He is not an alcoholic or a tobacco chewer. No history of any drug abuse or no history of any regular drug intake. Bowel and bladder habits are normal. Family history, he does not have any similar history in the family, and no history of malignancies in any other members of the family. So, a 60-year-old gentleman who is a smoker, present with complaints of swelling below and in front of the right earlobe for the past 3 years, with no comorbidities or previous surgeries. This is my summary, sir.
Can we go on to the first slide?
Yes, sir.
Your patient came with a swelling in below and front of the right earlobe. Tell
Yes.
me some swellings which can occur in the same plane.
You could have superficial swelling such as lipoma, and lymph node swellings could happen, and other swellings that could be there are any sebaceous cysts that could happen in that region from the hair follicles, and those are the few swellings.
Anything behind the ear, little bit? You can expect a post-auricular dermoid.
Yes.
It's going to be there for a long.
Yes.
Any bony swelling can occur at this site?
Osteoma of the mandible can happen.
Okay. Or even an adamantinoma can
Yes.
occur at this site.
Yes.
Okay, these would be the differential diagnosis which has to be considered for a swelling. What
Yes.
will be the direction of the lift of the ear lobule?
Upwards and posteriorly.
Posterior.
Anterior, sorry, upwards and anterior.
Okay. It comes forward and it raises upwards like this, right? It turns up and
Yes.
it moves forward. It doesn't go back.
Yes.
That is the direction in which it usually
Yes.
raises up. Okay. You said this patient doesn't have any pain. What are the painful swellings which can occur at this site?
Any stylar list causing obstruction of the parotid can happen, ma'am. And any infections leading to lymph node enlargements, lymphadenitis can be painful. Styladenitis, bacterial or viral styladenitis can happen. Those will be painful. And malignancy, change of benign swelling into malignancy will be associated with pain. And
So what will be the classical presentation of pain in styladenitis?
the pain increases right while eating and right after eating due to increased secretion of the saliva and causing obstruction at the duct.
So there might be a waxing and a waning pattern. Okay, the person with the styladenitis.
Yes.
Any other cause of pain?
In benign
In emergency setting,
any bleeding into the
an abscess.
abscess. Yes, ma'am.
Okay.
Yes, ma'am.
What would be the cause of an abscess?
An infection that leads on to a localized collection will lead to abscess. Parotid abscess can happen, or tuberculous cold abscess can be happening.
See, usually the commonest thing would be a bacterial or a viral etiology.
Yes, ma'am.
If it's going to be in a young adult or a young child, what could we think of? Bilateral?
Viral parotitis, most probably due to mumps virus.
Mumps viral infection. So what is the reason why a person develops a parotid infection or an abscess?
Mostly due to dehydration that puts frail and old people and also infants at risk of bacterial infection due to increased concentration of the salivary secretion, and also increased viscosity of secretions will lead to obstruction of the duct.
Okay.
Doctor, I would like to just point out that you are, hello, I'm audible?
Yes, sir. Yes, sir, you are audible, sir.
You said in chief complaint swelling below and in front of the right lobe of ear. He was so specific for this? The driver?
No, sir, he just showed the swellings, so I had to.
It must be just right side of the neck. See,
yes.
My point is that start thinking laterally. Don't jump right directly on the parotid. Okay.
Yes.
That is why madam has also asked you what are the differential diagnoses of swelling over that area. Okay.
Yes. Okay. Sir.
So this is very specific. So at least it should be vague. The chief complaint should be in the patient's word, more or less.
General questions onwards.
Yeah. Okay. Next slide.
So when can you have a rapid increase in the size of the swelling?
Malignant change in a benign tumor could have a rapid increase in size, or as I previously said, any bacterial parotitis changing into an abscess can have a rapid increase in the size, ma'am.
So when can a benign tumor become malignant?
Excuse me, ma'am?
When can a benign tumor become malignant?
Pleomorphic adenoma has chances to get converted into a malignancy when there is rapid increase in size.
What will be the duration?
It has a quiescent course of benign tumor, ma'am, and within few weeks to months, it increases in size to malignancy.
See, over a period of almost 5 years, 10 years, over that period only, these patients, when they are going to be having this pleomorphic adenoma for a longer duration of time, then there will be a change. Okay, there is about a 15% of people only, they go in for malignancy from a benign to malignant one, not all.
Yes.
Okay. Why you want to know about history of fever in this patient?
Any infective etiologies would be there, ma'am.
What is the duration of the swelling?
3 years.
Huh?
3 years.
3 years history of fever?
No, ma'am. Recurrent parotitis or tuberculosis or any granulomatous infections can be there.
Okay, we'll move on to the next slide.
Yes, ma'am.
What are the histories you like to ask for a facial nerve involvement?
Any history of dryness of eyes and any history of drooling of the saliva and any history of difficulty and slurred speech or something because of disarticulation of the mouth, and any history of asymmetry of the face that other people notice in the patient.
So
Yes,
usually
that
the
is most
symptoms of
important.
facial nerve palsy would be noted by the attenders. Per se, the patient, unless he specifically observes for these features, will not be able to appreciate these things, right?
Yes.
So most
Yes.
of the times the attenders will try to point out what are the changes which has happened in his relative.
Yes.
Asit sir wanted to ask something.
No, sir. No, madam. That is what I'm emphasizing, that it is usually the base of facial nerve palsy is noticed by the attendant rather than patient is complaining about drooling of the saliva or dryness of eye.
Sure.
Next slide.
1 second, previous slide, please.
Yes, ma'am.
You wanted to know about any other swelling on the left side parotid region. Why you want to know about that?
Causes of there could be bilateral parotid swelling in a few conditions, ma'am. Those could be due to infection, such as previously mentioned viral parotitis, ma'am, and autoimmune diseases such as Jorgen syndrome or some scleroderma and all other conditions can cause IgG4 diseases can cause bilateral parotid swelling, and few neoplasms such as Warthin's tumor can occur bilaterally. So
What is the age group for an Warthin's tumor?
usually affects the elderly. So
around the 6th or the
around
7th
60 or
decade.
70. Yes.
Usually adenolymphoma occurs in the bilaterally and usually on the lower pole.
Yes.
You tend to have this kind of a lesion.
Yes.
Right.
Rather, you would have asked about the swelling in the other part of the neck rather than left side of that looks more specific.
Yeah, you should ask about other swellings also in the neck because the patient can have a lymph nodal disease also.
Lymph node, yeah.
Right.
Yes.
So rather than specifically putting it on the left side parotid to say that we are trying to look for a bilaterality.
Yes.
So bilaterality, you should talk about Mikulicz syndrome also.
Yes.
You said about Sjogren's, but that is not said, right?
Yes.
Karthikeyan, any difference between Mikulicz and Sjogren's syndrome?
Sjogren's syndrome usually affects most of the glands, all of the glands, including the salivary glands, lacrimal glands, vagina and sweat glands and everything, sir. Mikulicz affects exclusively the salivary glands and the lacrimal glands alone, sir.
What are the antigens will be there in the Sjogren's and what will not be there? Which is reversible, which is not reversible?
Sorry, sir. I did not know that.
The Sjogren is mostly non-reversible.
Yes, sir.
Mikulicz after the corticosteroid therapy, because apoptosis is not happening fully. So the reversibility is a possibility there. And anti-Rho, anti-La, that antigens will not be there.
Yes, sir.
There are various other factors, sarcoidosis, other things can also cause a Mikulicz phenomena.
Yes, sir.
Okay.
How is the
Go to the
facial
next.
function graded?
Excuse me, ma'am. Facial function.
Yeah.
Sorry.
There's a grading system called as a House-Brackmann's grading system.
Okay.
Okay, for facial function grading,
Yes.
wherein it has been graded from grade 1 to grade 6.
Okay.
Wherein you try to ascertain whether there's going to be a palsy or it is going to be normal. So the first one is going to be normal. The second one is going to be a mild dysfunction. The third one is going to be a moderate dysfunction. And the fourth one is a moderate severe dysfunction. And the fifth one, there is going to be a severe dysfunction. And the last one, there is going to be a total palsy.
Okay.
By normal, I'm saying that the facial nerve is going to be normal. The second one, it is mild. There's going to be a slight weakness, which is going to be noted there. But there will be some amount of function might be there. And the next one is a moderate dysfunction where there will be an obvious, noticeable slight changes which might be observed in these things. Coming on to the last one, where I said was total palsy, and the fifth one, there will be only, a barely perceptible movements might be observed.
Yes,
So this is how the grading system is being advocated, and it has been advocated for the forehead, eyes, and that of the mouth.
Yes.
Okay.
It also gives a point also for every 0.25 centimeter,
Yes, sir.
2.5 millimeter, 1 point is given. So
1
based
point.
on that, House-Bergman index is calculated. So deviation, per lip deviation, all that. So each moment has 0.25 centimeter. There is a 1 point is given.
Yes.
Scoring is there.
Okay.
We'll go on to the next slide. So why you want to know about previous surgeries?
If we had previously had surgeries in the parotid region or something, we could expect recurrence of the tumor. And
Why does it recur?
Tumors such as pleomorphic carcinoma are much prone to seeding. So any small bit of tissue that was left behind will regrow to form recurrence.
No,
Actually,
it is
the
if
tissue is
surgeon.
not left behind. Most of the time, the pseudopods are only excised.
Yes,
The rest of the parotid will be left behind. So
Yes,
that parotid will tend to produce the next set of tumor.
Yes.
If surgeon knows that he is doing, he's dealing with a pleomorphic edema, usually they do it adequately. It is only when surgeon misdiagnose it's a lymph node, they just remove it, and then there can be a history of previous, there is recurrence.
Yes.
So only the scar will tell you.
Yes.
If it is a long scar, it usually never recurs.
Yes.
And second thing you have asked, history of mumps. What is the importance of asking past history of mumps? Does the mumps recurs?
Reactivation, sir. But any childhood mumps could persist as causing salinitis. Sir.
So mumps make the salinitis predisposing factor. You want to say like that?
No, sir. Mumps parotitis can occur, sir. The disease, mumps virus infection can stay in the
See,
system.
mumps parotitis, once it occurs, it gives lifelong immunity. Okay.
Yes.
Okay.
I think how will you differentiate lymph node and parotids only?
We can check the plane of the swelling, sir, because lymph nodes, if they are superficial lymph nodes, we can separate it based on the parotid fascia, sir. If we stretch the parotid fascia by asking the patient to open the mouth, the parotid swelling will become less mobile, sir. But the lymph node will have the same degree of mobility since it's located superficial, sir.
Up to the maximum limit, how much the node can be pushed? Or the parotid can be pushed? So
vertically, even if it's located upwards, it can go up till only the zygomatic arch, sir. It is the curtain sign.
Why?
Because of the attachment of the thick parotid fascia to the zygomatic arch, we are unable to move it beyond the zygomatic arch. Sir.
What is parotid region?
I'm sorry, ma'am.
What is parotid region?
Normal extent of parotid.
Oh, yes. It extends from the zygomatic
are the boundaries of the parotid area.
So you are you are muted. Unmute yourself.
Karthi?
Yes, sir. Yes, sir.
Yeah.
I'm
you're okay.
unmuted, sir. Am I audible?
Yes.
Now audible.
Now you
Go
can
ahead.
answer.
Yes, sir. The boundaries of the parotid region, sir. Anteriorly, it's by the posterior border of the mandible and the masseter muscle superficially, and posteriorly by the mastoid process and the external auditory canal, and superiorly by the junction of the auditory canal and the mandible posterior border, and superiorly by the zygomatic arch, and inferiorly the lower pole can extend freely. And deep lobe can extend until the parapharyngeal space.
How is the parapharyngeal space divided? Divided into a pre-styloid and a post-styloid space.
Yes.
And the deep lobe is situated in the pre-styloid area. Okay. We'll go on to the next slide. What is the significance of alcoholism?
Alcoholism is associated with dehydration most of the time, causing predisposing them to thyroids, and
Is it an inflammatory condition?
Silolith.
yes.
Alcoholism produce silolith.
Dehydration, if they are dehydrated, more common to have thyroids, sir. And it can also lead to parotitis.
Oh, what will be in alcohol, liver cell failure? What are the signs? One of the sign is
DCLD and decompensated liver disease produces dilated parotid swelling as well, sir.
okay.
So it's a non-inflammatory stylodinosis, which is happening in a person with an alcoholism.
Yes.
Right?
So bilateral.
Yes.
Yeah, it's bilateral. We'll go on with the examination.
Yes. In general examination, after obtaining consent from the patient, he was examined with adequate privacy in the sitting posture in a well-lit room. Patient was comfortable and cooperative for examination. He is a moderately built male with adequate nourishment. There was no pallor, ictus, clubbing, cyanosis, pale edema, or generalized lymphadenopathy. His pulse rate was around 80 beats per minute, regular. BP was 120/70 millimeters of mercury. On local examination, there was a hemispherical swelling of size approximately 3 × 3 centimeters, present just below and in front of the ear lobe, and extends 4 centimeters below the tragus and 3 centimeters posterior to the angle of mouth. It was obliterating the retromandibular groove. The surface was smooth, well-defined margin. Skin over the swelling was normal. No history of any scar. No, there was no scars or sinuses or dilated veins over the swelling. This is the examination inspection of the patient from the posterior aspect as well. There was no obvious inspective findings of facial nerve weakness. There was no deviation of angle of mouth or the ability to close the eyes tight. The swelling was not pulsatile. No other swellings noted in the contralateral side of the face or anywhere in the neck. On palpation, all the inspective findings were confirmed. There was no localized rise of temperature. The swelling was non-tender. The size was approximately 3 × 3 centimeters, and it was located in the right parotid region. The margins were well defined. Surface was smooth and firm in consistency, and the swelling was not fixed to the skin and was not fixed to the masseter muscle as well. And mobility was present in the transverse and the longitudinal axis. An examination of the oral cavity. The mouth opening was adequate. There was no trismus. The oral hygiene was good, and the right parotid duct opening was seen at the level of second molar tooth, and there was no discharge or pus discharge noted in the duct opening. There was no fullness over the right posterior facial pillars. The tonsil was normal in position. There was no displacement of the tonsil medially. The swelling was not palpable bimanually. The contralateral parotid gland was normal. There was no palpable neck nodes on either side of the neck. and examination of the facial nerve was normal. There was no facial nerve weakness. And other system examination, the cardiovascular system was normal, both heart sounds heard, no added sounds. Respiratory system was uneventful, no normal vesicular with sounds, no added sounds. Abdomen was soft, no tender, no palpable mass. And the central nervous system examination was normality. And to summarize, a 60-year-old gentleman who's a smoker, person with complaints of swelling below the right earlobe for the past 3 years with no associated symptoms, with no significant past history, and on examination showing a non-tender, well-defined, firm swelling of size 3 × 3 centimeters in the right parotid region with no skin or deep tissue fixity, and not bimanually palpable, no associated facial involvement, and no cervical lymphadenopathy. My provisional diagnosis will be a right benign parotid tumor and possibly pleomorphic carcinoma or Walden's tumor.
Can we go to the inspection?
Yes, ma'am.
Are you able to appreciate the margins as a well-defined margins all around?
Yes, ma'am. Because
on inspection,
the image seems.
from the picture, I'm not able to visualize the anterior margin. It is almost diffuse.
Yes.
Okay. I don't think it is well-defined margins.
Yes.
Somewhat a diffuse swelling, which is I'm not able to appreciate, right?
Yes, ma'am.
Next slide.
You will look for some scar sinuses. What sinuses you looked in that area?
Any lymph node that has formed a fistula or a parotid fistula, that can be there.
No, you are put it there in the wording. No scars, no sinus. Is it just a routine, or you have looked for some sinus? And unless you look for some sinus, you will not write now.
Yes.
So what sinus you look for in that region?
Preauricular sinus could be there at that location, sir.
Okay. Go ahead. Go ahead.
Yes.
No, madam asked you the second slide, no, on the palpation slide.
There is no facial asymmetry. So what were you trying to look for?
Any
next slide.
Yes. Any involvement of the facial nerve would present clinically with facial asymmetry. No?
So what would be the first feature you look for? There will be an obliteration of the nasolabial furrow.
Yes.
Okay, try to look for that.
Yes, ma'am.
Okay, on inspection. So coming on to palpation. What is the plane of the swelling?
It is deep to the parotid fascia. Superficial to the masseter and deep to the parotid fascia.
Deep to the parotid fascia, within the parotid fascia.
Within the parotid fascia. Sorry, sir.
Okay, did you palpate for the parotid duct?
Yes, ma'am, I did. Bidigital palpation of the parotid duct was done.
Bidigital palpation. Where did you palpate?
One index finger inside the oral cavity and thumb outside the oral cavity over the masseter muscle. Rolling of the index finger and the thumb over the medial buccal mucosum.
So usually when you try to ask the patient to clench the teeth, what happens? The masseter becomes taut. On the anterior border of the masseter, when you run your finger, you'll be able to feel for the duct. Okay, and the other aspect, you try to inspect on the inner aspect. And moreover, you said on palpation, you did a bimanual examination somewhere.
Yes.
Is that correct?
Yes.
Why you want to look for a bimanual examination for a tumor which is going to be placed so posterior and almost down? Still, you don't want to do a bimanual examination here?
To look for any deep moment, I could.
See, bimanual means what happens? You keep one finger inside and the other one outside. That only we call it as a bimanual.
Yes.
When you want to do that means you're doing only an intraoral palpation. You're not doing a bimanual examination, right?
Yes, ma'am.
And moreover, the parotid is 80% superficial.
Yes.
Hardly 20% is the deep lobe.
Yes.
In contrast to submandibular, where there is a majority is in the deep lobe, and you push from
Where will you look
inside
for
and
deep lobe?
Posterior to the mandibular border, sir. And one hand outside and posterior to the mandible, and one finger inside the oral cavity, posterior to the retromolar region.
Basically in tonsillar fossa.
Yes.
It's a bidigital palpation. Okay.
Very difficult to do. Most of the time, your patient will not cooperate unless you
This
have a lump.
basically is used for submandibular for bidigital palpations to differentiate between the gland and the node, they would say. Okay.
So deep lobe enlargement is generally an inspectory finding. You try to look for the partial pillars which is going to move medially and check whether the uvula is going to be shifted towards the opposite side. So try to look for that. It's only an inspectory finding. Okay. When you try to put in your finger, patient usually will never cooperate, right? So that will be a great difficulty to do your bimanual or bidigital palpation for your deeper lobe. Okay.
when will you suspect there is a deep lobe enlargement? From symptom, can you suspect?
Any swallowing difficulties the patient presents with and painful swallowing.
Even snoring also. Snoring and swallowing difficulty. In that case, you can suspect deep lobe enlargement.
Yes.
Okay.
What is rule of 80?
80% of the parotid tumors are benign, and 80% of the parotid gland is superficial, and mostly affects the
80%
female.
of salivary gland enlargements are from the parotid. 80% of them are benign, and of them 80% are of pleomorphic adenoma, and they are benign in nature, right? And some people even add that 80% of the deeper lobe are again they are going to be benign only. Suresh, you wanted to ask something, no?
No, so your working diagnosis is parotid tumor, benign, probably benign. How we are going to proceed?
I would go ahead with non-invasive investigations first, sir. So I'd do ultrasound of the local region, ultrasound parotid region with opposite side and based on
you
that,
want to keep any differential diagnosis here? You want to keep any differential diagnosis, or it is just the parotid?
Chronic lymphadenitis can be there, sir.
It is hard inconsistency. Swelling is hard inconsistency?
No, sir. Firm.
Firm.
And what is happening to the ear lobule?
It's slightly displaced upwards.
Doesn't look like, is it? In this picture, it doesn't look like.
Yes, sir.
So if the ear lobule is not lifted up with such a big swelling which is there, what will be the second diagnosis here?
As ma'am said, an osteoma or other benign lesions there.
You said it is mobile, no?
Yes, sir. Mobile.
So osteoma is not mobile.
Yes.
What is the commonest thing when you see a node here? What?
Second is neck.
Secondary of the neck. That is a very important differential diagnosis in this case. The facial nerve is not getting involved and the ear lobule is not lifted up. So that you have to keep a possibility of the secondary. Yes. Okay, go ahead with your investigation.
So what are the areas of lymph nodes you need to examine for a parotid?
Intraparotid nodes can be first involvement, which will be associated with parotid swelling, and then it will listen down into the upper jugular and lower jugular lymph nodes. So level 3, 4, and 5.
3, 4. It's usually the level 2 group of nodes and level 5A are mostly involved for your parotid lesions.
Yes.
Okay. So what investigation you want to do as a first line of investigation? And why?
First, I would do an ultrasound of the local region to find out if it's within the parotid gland or if it's on any other plane, such as the subcutaneous plane. Possibility of lymph nodes or lipoma will be excluded based on that. And following the ultrasound findings and ultrasound duplex can be done as well to assess the vascularity of the tumor. And I'll follow that up with fine-needle aspiration cytology to get a cytological diagnosis of the same swelling. And if it turns out to be a parotid tumor, I'll get routine preoperative investigations for further management.
So you
See, in ultrasound, you want to know about the origin from where it is arising from, or you want to do something else.
To assess the plane where it's arising from and also assess the margins or a deep lobe involvement.
What was the consistency of your tumor?
Firm and consistency.
Ultrasound will clear whether it is a solid or cystic. That's the more information what we are going to get. Okay. And obviously parotid, you know clinically the extent all this thing, especially deep lobe, you cannot generally assess with ultrasound. You need a deep lobe involvement, we need to go for another modality. So ultrasound, what if given a choice, what investigation would you like to do for a parotid?
Between ultrasound and higher investigation, sir?
No, it is a choice of you. Everything is available for you.
I'll go ahead with MRI of the local region, sir.
Okay, MRI is very good. Okay, why do you want to do an MRI?
Based on MRI, the soft tissues can be differentiated, sir. So
Okay, very good.
involvement of the deep lobe is easily identified because facial nerves seen, sir.
Okay.
Also, how far the extent of the tumor is can be assessed, sir. Consistency can be much more elaborately assessed, sir.
Okay. Especially in malignancy, the one more advantage of doing an MRI.
Operability can be assessed.
No. The perineural invasion. Okay, that is very clearly it will be defined in the MRI.
Yes.
Okay, for that reason, an MRI is preferred over CT scan.
But which will tell you about the operability with the as a pterygoid space involvement, skull base involvement.
CT is better, sir. With bone involvement. Skull base or pterygoid plate involvement, CT is
Perineural is only very adenoid cystic carcinoma only commonly involving with it. So in this case, you have done the CT or MRI?
No, we did not do so.
So if you are having only X-ray, then what view you will take?
I'm sorry, sir? X-ray.
If you are having only X-ray.
Yes, sir. X-ray of the skull, APAU and lateral view, sir. And yes.
If you have a gland, you are expecting a calculi, suppose subpandibular gland, what view of the X-ray you will take? So you need to write an X-ray, no? What X-ray you want? With the open mouth, oblique view. So in specification, you have to look into that. So you will try to, if NIC is not giving you a result, will you do a true cut biopsy?
No, sir. Not in the parotid region, sir.
Why?
Is true cut biopsy absolutely contraindicated, or are there indications for a true cut biopsy?
There are a few indications for a true cut biopsy wherein true cut is initially hesitated because of the seeding possibility of malignancy, ma'am, and also because of the close proximity of the facial nerve and neurovascular structures as well. And rare indications could be in case of overt malignancies that are gone into the T4 A or B lesion, and recurrence of the tumor with already existing patient of palsy, where we can risk doing a true cut biopsy.
Anything more you want to add? When you suspect a lymphoma in the parotid, a true cut biopsy will be helpful.
Yes,
right?
Which investigation you will go first, MRI or true cut biopsy?
MRI, sir. Because after any invasive investigations, there's the chance of the imaging modalities getting altered because of the hemorrhage and inflammation that produces locally, sir.
Right. One more point I would like to highlight is that in CT scan, you need to ask about any diameter implants. If they are there, you cannot go for the CT. Otherwise, it will produce artifact effect.
Yes.
So investigation, first you do an ultrasound to look whether it's solid or it is going to be cystic, and in addition, you can be able to identify if the patient is going to have any lymph nodes in that area also. Right, that can be picked up. You said about FNAC. Right, for FNAC, what is the grading system you use here? Or a classification? We have this Bethesda system, no? Likewise, for Parotid, what is the system? It's called as the Millen's classification of cytopathology for salivary gland lesions.
Almost same, but you have to carefully look.
Yes.
It's almost same, except for the fourth one, where they say it is a salivary gland of uncertain malignant potential. Remember by the mnemonic SUMP, S-U-M-P, uncertain malignant potential. Right. Rest of everything is almost the same, like yes. A non-diagnostic, non-neoplastic, or the other one is going to be a benign one, likewise, right? Yes. Only thing the classification terminology is being under Millen.
Yes.
Why it is called mixed parotid tumor?
Because it has both epidermal and mesenchymal components within the same tumor, sir. So it's called mixed parotid.
Any nuclear medicine, any role?
Excuse me, sir?
Nuclear medicine.
Nuclear
any role
medicine.
Of nuclear medicine?
Technicians can be done, sir. A technician can, there'll be hot nodules in case of Walden's tumor and also in oncocytoma, which are both high mitochondrial activity tumors. So we can use technician scans.
So, as Madam has already said, at the age about the 45 years old, patient who has a smoker, who has a lower pole tumor. So when we are suspecting a Walden's tumor, and technetium is indicated.
Yes.
So having done that, if you are thinking it is a pleomorphic adenoma, and what you are going to do further on this?
Once I'm done with the diagnosis, I will go ahead with getting a consent from the patient and anesthetic assessment for superficial parotidectomy, sir. Because the minimum surgery that we done for pleomorphic adenoma is superficial parotidectomy. So I'll plan for surgery next.
What consent you will get from that? What advice you will say that what is the problem of this surgery, and what advice you will get?
Sir?
No, what the caution you will give to the patient when you are doing the surgery?
Preoperative consent should explain the possibility of facial nerve weakness that is there, because most people will be hesitant about cosmetic reasons, and others that will be for fistula formation or Ray's syndrome will be explained, and other general preoperative consent for general anesthetic surgery should be explained. And
pleomorphic adenoma is a benign condition.
Yes.
With so much of risk involved, are you still going to advise the surgery for the patient?
There is a possibility of pleomorphic adenoma to progress into malignancy, sir. So I would suggest the patient to have surgery, sir. The risk versus benefit should be analyzed, sir. So in this case, the
what malignancy you get?
Carcinoma X pleomorphic adenoma, where
Which is the most aggressive tumor.
What are the signs of eliciting that it's a malignant tumor in a parotid or a benign turning into a malignant, as we say? When you suspect?
Onset of pain in the swelling, any new swellings that could be possibly due to lymph node involvement, and ulceration or skin changes that could happen, and sudden increase in size of the swelling, onset of facial nerve weakness symptoms. All these could be denoting towards malignant change, sir.
And along with the lymph node enlargement. So you want to do a superficial parotidectomy?
Yes, sir.
Okay. So how will you do, or what incision you will do for the parotid?
Modified brace incision or the cervicomastoid incision, sir.
So how will you identify the facial nerve? What are the landmarks?
Facial nerve could be identified anterogrally from the trunk or retrogrally from the branches, sir. Most commonly, we identify from the trunk, sir. The pointers could be from the superior border of posterior belly of digastric muscle, which is easiest, and others are from the temporomastoid suture line or Conley's pointer 1 centimeter below and deep to the triangle pointer, and insertion of digastric muscle at the styloid process where the facial nerve emerges, and retrogradely by tracing the branches of the facial nerves.
Any arterial bleeding or arterial point which will be
fresh
close
bleeding
to that?
that arises from the stylomastoid artery, the sentinel branch of the stylomastoid artery indicates facial nerve that be situated 4 to 5 millimeters below the sentinel arteries.
So you are interested only on a facial nerve or any other nerve also you are in a parotid surgery?
Great auricular nerve, if possible, is preserved so that in case there is any facial nerve, we can use it for.
It has two branches, anterior branch and posterior branch.
Sir?
Which one you will try to preserve?
I don't know. Posterior branch.
Anterior difficult to preserve, but posterior branch you can preserve. It supplies the pinna here, especially in the people who have the scuba diving. Only the temperature variation will be a difficulty if that nerve is cut. It will not be able to appreciate the temperature.
Yes.
Suppose your clinical diagnosis is a malignant parotid. So what do you want to do?
I will go ahead with the radiological investigation that I previously planned on, sir. MRI or the CT of the head and neck region, process for the deep lobe involvement or perineural invasion and lymph nodes, sir. Okay. If the tumor is confined to the parotid gland and there's no evidence of perineural invasion, I will go ahead with conservative parotidectomy, sir. And
conservative parotidectomy means you will do conservative total parotidectomy or
total conservative.
Superficial parotidectomy.
Total conservative parotidectomy.
Total conservative parotidectomy. Okay.
With nerve preserving.
With facial nerve preservation. Okay. And on table, we'll try to preserve the facial nerve as much as possible, unless there is
as much as possible.
Unless there's cross invasion of the facial nerve, we try to preserve the facial nerve.
Okay, suppose if you see there is a few branches is involved. Okay, so on table, but there is clinically there is no.
I'm not able to hear the voice, sir. Sorry, sir.
See,
yes.
if you know preoperatively it is a malignancy,
yes.
and we can if the nerve is passing through or going through the tumor, it is always better to sacrifice. Okay. And which branch you can sacrifice, which is most important? If you are given a choice to preserve one branch, which one you will preserve?
Among the 5 branches, which one you will give more?
Zygomatic branch will be preserved, sir. And buccal branch can be compromised, sir. The recent one.
No, that is 3 plus 2 it comes.
Yes.
Entire zygomatic temporal we are going to preserve. Among the 5.
Zygomatic branch, sir. I'll try to preserve the zygomatic branch because of the ocular symptoms and complications that could arise because of inability to close the eye properly, sir. Since that is more important, I'll try to preserve the zygomatic branch, sir.
Okay. Suppose if the marginal mandibular nerve is damaged, what will happen?
It usually supplies the platysma and the angle of the mouth, sir. So there will be deviation of the mouth, sir.
Okay, how do you drape the patient for a parotid surgery?
We put the patient on with the head up and turn to the opposite side with draping that can be left to show a part of the face, the angle of the mouth and the lateral border of the canthus, sir. So that we can monitor the facial nerve intraoperatively if needed, sir.
If you have to put the nerve monitor in that patient, where are you going to put the needles?
On each muscle that will be supplied by the nerve, sir.
Which muscle you will put?
From the forehead, we'll put on the occipital frontalis, sir, and the orbicularis oculi and buccinator muscles.
Orbicularis oris muscle.
Orbicularis oris. Sorry.
So the 2 most important will be oculi and the oris. Now you detect that you have damaged the facial nerve at operation. What are you going to do?
It will depend on the degree of damage. If there's total transection, I'll on table. If I diagnosed, I will try to do a grafting, sir. For benign conditions, I can use the great auricular nerve, sir. Or otherwise, I'll try to use the sural nerve.
Is the grafting required in all cases?
No, sir. If it's reachable, if there is no defect within the nerve, I can directly anastomose, sir.
So how much defect you can cover without the graft?
I don't know exactly, sir.
So 1.5 to 2 centimeters.
Yes.
That much you can mobilize.
Okay.
And you can do a direct suturing of that.
Yes, sir.
If it's more than that, then you can use either the greater auricular nerve there. What other nerves can be used?
Great auricular or sural nerve grafting can be used, sir. Ideal grafting sural nerve, sir.
So you detected the facial nerve injury post-operatively. What are you going to do?
I'll start that patient on oral steroids prednisolone, sir, and start him on exercises for the facial nerve region, sir. And for the eyes, if there is degree of facial nerve weakness, will be assessed, sir. If he has inability to close the eye, I'll have to put the patient on normal artificial tears eye drops, and if there is drooling of saliva, I'll have to give the patient sling or the slint of the mouth, sir. And exercises for the facial nerve will be started. And if it's assessed immediate post-op and the patient needs repeat surgery, we'll post the patient for re-exploration, sir.
Can you do any surgery for the exposure keratitis? The patient is having exposure keratitis. Can you do any surgery?
Surgery for the eyes, sir?
Exposure keratitis.
Yes, I can do a lateral tarsorrhaphy for long-term exposure keratitis.
Why not the medial tarsorrhaphy? Why the lateral tarsorrhaphy?
Because in the medial region, the lacrimal lacrimal system drainage is there, sir. So if we do the raphy there, there'll be continuous tearing of the eyes, sir.
That is why you always do a lateral one, not the medial one. So, are you going to do definitive repair for the facial nerve anytime?
I'll attempt for conservative management, sir. If it fails, I'll have to go ahead with surgery, sir.
What surgery can be done? Definitive surgery later on?
Grafting of the facial nerve, and if it's not possible, I can get the nerve anastomosed with the hypoglossal nerves.
What are the complications of parotidectomy?
Parotidectomy. Usual complications such as hemorrhage, infection, and seroma collection happens, sir. And specific for parotid, we could have Frey's syndrome, fistula formation, and flap necrosis.
What is Frey's syndrome?
Salivary sweating, increased sweating, and redness and warmth of the parotid gland region after food intake is called as Frey syndrome due to abnormal connections that form between the parasympathetic system and the skin glands, sweat glands in the skin.
What is the treatment for that?
Medical management can be done by botulinum toxin injections or local topical application of antiperspirants can be done, sir. And if all else fails, we need to do surgery and go ahead, sir.
What are the options you have for the preventing that?
The most common would be to take a flap that is thick enough to prevent abnormal parasympathetic connections. And after post parotidectomy, if the defect is too large, we can do a flap cover to prevent abnormal connections. Flap could be sternocleidomastoid flap or any free flap could be given, sir.
Just for remembrance of the complication of the parotid surgery, you can just say that there are 5 Fs are there. You know those? What are those 5 Fs? Everyone can remember by that.
Facial nerve weakness, fistula formation, Frey's syndrome, flap necrosis, and
fluid collection.
Something can be collected there.
Fluid collection.
Yes.
So that is a seroma formation. So you can remember by 5F the complications after the parotid surgery.
Yes.
So if the patient comes to you with a fluid collection, what you will do?
First thing, I will check what consistency of the fluid is, sir. And if it's soft and cystic, I'll aspirate to check what the fluid is. And if it's seroma, I'll completely aspirate the fluid and watch for if it collects again, sir. If it does not collect again, we can manage conservatively, sir.
So most of the time it responds. No? With the seroma, there is no active involvement is not necessary. Unless it forms as a fistula formation. So in what is the nerve supply to the parotid?
Parasympathetic fibers for lacrimation, sir. And
from where?
Yes, 8th, 9th nerves. Glossopharyngeal nerves.
No, which is the salivary nucleus? From there it's coming.
Yes. From the salivary nucleus through the glossopharyngeal nerve, it reaches the parotid gland.
Which nerve?
Glossopharyngeal.
From there? What ganglion?
Inferior salivatory ganglion.
otic ganglion, the inferior salivary ganglion, it's coming vasopharyngeal, then comes otic. From there it comes. So the root for the both the salivary glands must also, because you are doing very well. So we'll be asking some core questions into the anatomy, into the physiology, that will be also asked for.
What is retrograde parotidectomy?
In cases where it's hard to reach for the facial nerve trunk, and mostly because of repeat surgeries in malignancy, we can identify the branches while dissecting the superficial lobe, and based on the branches, we'll trace the facial nerve trunk. That's retrograde.
Which branch will they choose?
I exactly don't know.
The marginal mandibular nerve.
No.
So,
what are the indications for post-op party in a malignant parotid tumor?
Deep lobe involvement, if it is there, we'll go for radiotherapy, sir. Lymph
No,
node
deep lobe involvement is not the indication, because if deep lobe is involved, you have to go for a removal, total parotidectomy.
T4 A lesions, sir. T4 lesions.
T3, T4 lesions.
Lymph node metastasis, sir.
The lymph node metastasis, margin positive or close margin, or high-grade tumor.
Yes.
Okay, these are all the indications for
radiotherapy.
Post-op party.
Even if
So
you suspect perineural spread, if you are suspecting
follow-up is important or not in a malignancy.
Sorry, sir?
Especially if you have a patient of adenoid cystic carcinoma.
Yes, sir.
So there the perineural spread and the radiotherapy is more.
Yes.
Suppose the patient comes with a recurrence.
Yes.
So what is your option in front of?
If it's a benign tumor that recurred, I will go for investigation modality, and if it's a pleomorphic adenoma, again, I will do a superficial parotidectomy with radiotherapy post-operatively, sir. If it's a malignant tumor, I'll have to manage according to the previous plan, sir, based on the condition. Sir?
So again, you have the option of either surgery or radiotherapy.
If it's a benign tumor, I'll do surgery followed by radiotherapy, sir. It's a malignant tumor.
Even if it's a malignant tumor comes with a recurrence, and that's a possibility. If you can do the resection, then you can do the resection and then go for radiotherapy. How do you follow up the thyroid surgery? Parotid carcinoma?
I'll ask the patient to follow up on every 3 months for the first year, sir. And after that, every 6 monthly for 2 years, and yearly for 5 years, sir, to check clinically, sir. And if there is any suspicious swellings, I will do an ultrasound and FNAC.
Why do you want to have a long follow-up, especially for parotid cancer?
Because the chances of late recurrence is high with parotid tumors, sir.
Which parotid tumor?
Pleomorphic adenoma.
Adenoid cystic carcinoma has a very peculiar feature that it may recur even after 10 to 15 years. Okay. So that's a follow-up is very important.
Yes.
So while doing a parotid surgery, when now you think you can injure the facial nerve?
While we are trying to address for hemostasis and we use monopolar cautery there, I'll be cautious for facial nerve injury. And if there is dense adhesions and I'm not able to identify the trunk initially, I'll if I'm going for retrograde tracing, there's a high chance of facial nerve injury.
So usually to prevent it, what are the things you like to do?
Going by protocol, tracing the sternocleidomastoid and digastric, which will lead to the parotid trunk. Based on that, I will identify the parotid, facial nerve trunk. Based on that, I will identify the facial nerve.
So whenever you raise the anterior flap, you should not go well beyond the anterior margin of your parotid limit, right?
Yes.
Then what happens is when you're tracing the branches out, there are chances of you making an injury there. And one more thing you need to remember is sometimes the deep lobe might enlarge so much, it will bulge and it comes anteriorly. And you might be thinking it might be the superficial lobe, wherein the trunk might be splayed over.
Yes.
And you, without knowing that it's the deep lobe which is coming up, you might injure the facial lobe. So you need to be more careful.
Okay, what is Hamilton belly technique?
Sir?
Hamilton belly technique.
No. I do not know.
Okay, what madam was asking you, that you trace the facial nerve from its branches.
Yes.
Okay, that is called as Hamilton belly technique. What is the Hopsley technique in relation to the parotid?
We are exposing part of the face intraoperatively to monitor the facial nerve. Is the Hopsley technique.
So what we were discussing, that the draping the parotid surgery, so that is the Hopsley technique. What is the Blair incision?
An incision extending from in front of the tragus around the earlobe and along the 2 centimeters below the mandible. Sir.
Not that one.
That is modified.
Blair incision is used for which disease in relation to the parotid?
Silolith, sir.
It is for the parotid abscess. Okay, when you are making
Along
a
the facial nerve.
training the parotid abscess, you have to save the facial nerve.
Along the facial nerve, sir.
So that is the Blair incision. What is a Godwin tumor?
Sir?
What is a Godwin tumor?
Godwin, Stephen.
It's a benign epithelial tumor of the parotid and which may be bilateral. So when you are discussing the bilateral parotid tumors, so this tumor can be a bilateral tumor.
So
What is eschimoma? It's a type of the carcinoma of the parotid, which is primary epithelial carcinoma. What is cut nut tumor? Because you are doing so good, that's what I am asking. All those things here.
Learning.
So you please give the answer, sir.
It is a sclerosing sialoidinitis. Okay. So it's a benign thing, usually occurs in the submandibular gland. It may occur in the parotid also, but it may occur in the submandibular gland. It's a benign pathology.
Yes.
Okay.
What is radical parotidectomy?
And there is extensive malignancy that involves the parotid gland and surrounding tissues. We'll have to remove the parotid gland along with the facial nerve and the masseter muscle
Where do
and
you cut
mandible. Sir?
What part of the facial nerve you remove?
Involved part of the facial nerve branches and we remove, sir.
What surrounding structures you remove?
Masseter muscle, mandible bone if it's involved, and part of the skin if it's involved as well, sir. Extended radical. And ear lobe cartilaginous part of the ear external auditory canal can also be removed, sir.
So masseter, what is that muscle?
Sir?
Masseter, what is that muscle?
Masseter is elevator of the mandible, so it's the muscle of the mastication, sir.
What is that function?
It closes the mouth, sir. With
mouth is by?
Sir?
Opening of the mouth is by?
Lateral pterygoid muscles is only opener of.
Where it originates?
On the lateral side of the pterygoid plates. Sir.
So medial pterygoid is from?
Medial aspect of the lateral pterygoid plates. Sir.
Which pterygoid plate?
Sir?
Which pterygoid plate?
Both originate from the lateral pterygoid plates. Sir. On the medial aspect and the lateral aspect. Sir.
What's the nerve supply?
Nerve to lateral pterygoid. Pterygoid. Pterygopalatine nerve. Pterygopalatine nerve.
Pterygopalatine.
Yes. No, sir. Sorry, sir.
So what is the muscle of nerve of mastication?
Trigeminal nerve.
Which part of the trigeminal?
Mandibular branch.
So only mandibular has the motor branch.
Yes.
All other two are only a
sensory branch.
Canavel sir, I think is good.
Yes, sir.
I think we should give the student to ask any questions if there are. Karti, I think you did well. I think I will take comments from the other faculty. Kana sir and Suresh Kumar sir, Kelal sir, I think they were drilling him and he was able to cope up. Shows the quality of general surgery training at Coimbatore Medical College. So,
it's up to Srinivasan sir.
Thank you. Thank you. I thank my guides and my senior PGs for helping me out and teaching me.
Karti, do you have any questions, comments to clarify because we have the national faculty here?
I have one curiosity, sir. One is, as I observed from previous surgeries, and during parotid surgery, even if we preserve the facial nerve carefully, there is some degree of facial nerve weakness in the immediate post-op period, sir. What could be the reason and how to manage, sir? Could it be because of neuropaxia or inflammation, sir?
See, the problem is
this is just like a neuropraxia which is there, isn't it? You know, you are working so close to the nerves. So
yes,
whatever the cautery and all those things which you are using, there is always some thermal spread is there. But it's a temporary phenomenon. Okay. Once you identify the nerves, you are sure about that this is a temporary phenomenon of a neuropraxia is there. It's not a neurotomesis is there.
Yes.
So this patient will recover after some time. You can assure the patient about that.
And what is the role of
will resolve in 3 to 6 months time?
Okay.
Okay.
And what is the role of steroid therapy in the immediate post-op to decrease inflammation, or is there any other any other reason for giving steroids?
It is not for increasing the inflammation, it is for decreasing the inflammation.
Yes.
Okay, some people, though there is no rationale for that, but it is being used. Like in the thyroid surgery, when you are doing that, sometimes, especially when you are doing a total thyroidectomy, the people, they give the steroids to have that avoidance from the neuropraxia by the bilateral recurrent nerve. Okay. Similarly, here also you can use a steroid for that. But as such, there is no hard evidence for that.
Mainly, reduce the inflammatory reaction around, and edema formation will be reducing. So, because edema is the one mainly, it is making a compression effect on that.
Okay. Those are my only questions, sir. I thank everybody for giving me this opportunity, sir. And I'm blessed to have such a good faculty in my institution, sir.
Suresh Kumar, your comments, sir, please.
Yeah, I'll say yes, done very well, and all the best for his future.
Thank you, sir. Thank you, sir.
Both present prepared very well. And they
Is there any role for enucleation, madam? Is there any role for enucleation?
No, sir.
Somebody was teaching, madam, that Bailey gives its any small tumors can be enucleated. I want to know.
So there's one more thing which Bailey gives, that's extracapsular dissection of the tumor. It is almost looking like an enucleation.
It's not, madam. The student says, can we accept? Because the minimal biopsy, some people say suprafacial parotidectomy. But some people, if the tumor is less than 3 centimeters, you can do an enucleation and leave it and come. Because the standard textbook gives, so if the student says, can we accept it? That's what I leave it with that.
For a parotid, superficial or conservative parotidectomy,
Yes,
But
sir.
for the Warthin's tumor, exclusively when the Warthin's tumor it is there, when it's 100% it is a benign, there is no possibility of pseudopod. So there, the enucleation or the limited extracapsular excision is accepted once. But parotid per se, when they are thinking in terms of pleomorphic adenoma, I think as on date, it is better to say is a conservative parotidectomy or superficial parotidectomy is the best.
I think if the tumor is in the tail of the parotid is there, then you can sometimes save the extracapsular variety. A small tumor from the tail of the parotid is there. But if it is from the main body of the parotid is there, then you have to go with the classical superficial parotidectomy.
Thank you, sir. Thank you, invited faculty, Dr. Suresh sir, Anandi madam. Asit Patel sir has to leave for a PG exam tomorrow to catch a train. He left. Thank you, Srinivasan sir, Kanna sir, Jailal sir, Karthikeyan, Karunakaran sir.
Anandi madam was we are happy to see Anandi madam in the full form today.
Thank you, sir. Nice to meet you.
Thank you, madam. Thank you, everybody. Good night.
Thank you. Lot of learning points.